So stem cell therapy and exosome therapy is something which is a hot topic right now. And because of that, I decided to spend a bit of time today. And more clinics around Southern California at least, and even more in Northern California, offer type of therapy for their patients. So what is a stem cell? So it's, as you know, it's a cell which can replicate itself, and it can be differentiated into many cell types. So we all come from a single stem cell. So when we're talking about stem cell therapy, you need to explain your patient that there are different types of stem cell therapy. And if you explain your patients and be proactive, then you can be more kind of, in charge of the situation. So there's a hematopoietic stem cell therapy, mesenchymal stem cell therapy, embryonic stem cell therapy, and exosome therapy, which is kind of mesenchymal stem cell derived therapy. So let's get started with the oldest one. Bone marrow transplantation was first done in the 50s. And after that, this was and still one of the most common procedures done for patients with various malignancies. The procedure involved partial or total replacement of the hematopoietic system of recipient with hematopoietic stem cells from any donor type or source, bone marrow, peripheral blood, cord blood. And so this is a procedure defined as hematopoietic stem cell transplantation. So the main goal of the therapy with hematopoietic stem cells in patients with autoimmune diseases is to eradicate autoreactive immune cells and kind of bring the system back to normal and naive state. So, and the remission in patients who undergo through the therapy is a result of true reconfiguration of the immune system instead of immune suppression. So this is pretty good looking theory, however, it's kind of brutal therapy. So in 1989, a study in animals showed that if you irradiate rats and then infuse them with allogeneic bone marrow from rats resistant to arthritis, so these rats don't develop adjuvant-induced arthritis. And basically, there were some incidental reports which were published in the 50s and 60s that patients who underwent bone marrow transplantation or hematopoietic stem cell therapy, and those patients who had autoimmune diseases, the autoimmune diseases were cured. So it was the first sign that, there's something behind that. So in 1994, the first article was published which showed results from 7 patients with RA complicated by severe aplastic anemia who underwent bone marrow transplantation from HLA-matched siblings. So we're talking about not autologous, but allogeneic. So 3 patients died, and 7 patients survived. Although 3 patients died as a result of transplant, RA resolved in all 7 patients. So meaning 3 patients died and 4 patients survived. So, the first official therapy of patients with autoimmune disease was described in 1996, official therapy with autologous hematopoietic stem cells. And it was a patient with scleroderma and severe pulmonary hypertension who was denied lung transplantation, but benefited from stem cell therapy. So how does it work? So it's a process, and it's a brutal process. So initially you select patients, you mobilize stem cells. So what does it mean? So you're trying to move stem cells from bone marrow into the bloodstream. So how do you do it? So you're using cyclophosphamide, which is a chemotherapeutic agent, and if you do it in the form of infusion and specific dose, it can mobilize stem cells. or you can use GCSF, which is a granulocyte colony stimulating factor. So you mobilize stem cell into circulation, you harvest blood, you isolate stem cells, which by definition CD34 positive cells, so there's a procedure for that. And after that, you wipe out completely patient's immune system using typically heavy dose of chemicals such as fludarabine and then antithymocytic globulin. So basically, you're using chemotherapy to kill all the immune cells in patient's body. And then after that, you infuse harvested stem cells back. So, and recovery takes around a couple of months. So what's been shown that if you look at autoimmune disease, and it's a very important slide for quite a few reasons. So if you look at pre-transplantation situation, and if you start analyzing so-called T-cell receptor diversity, so you can see that in a lot of, almost in all patients with autoimmune diseases, there's a problem with the T-cell receptor diversity. So what does it mean? It tells you that there are dominant clones of T-cells which kind of, dictate the immune system what to do and how to do it. And so eradication of these clones can benefit the autoimmune diseases. And so as you can see, you induce lymphopenia, and then you completely replace immune system with stem cells, and as a consequence, you have completely different picture. So the T-cell receptor diversity is completely different. It's back to normal. So this is a holy grail to understand, the whole autoimmune diseases. So it's because of that people think that autoimmune disease is very similar to malignancies, where you have a dominant clone of cells which kind of suppress other clones. So it's very similar here. So you have dominant clone of T cells which dictate your body what to do and how to behave. So this is a table, kind of a complicated table, but we'll go over. So it shows results from hematopoietic stem cell transplantation patient with autoimmune diseases from 1996 to 2011. And so basically, as you can see, there were a couple thousand patients treated. Success rate is around 60–70%. There's a pretty good mortality. And overall, 1 year survival is not the greatest one. Patients who underwent autologous transplantation doing better than those who get allogeneic stem cells. And as you can see, a 5-year progression-free survival is 43% in autologous and 65% in allogeneic. However, 1 year survival is 70%, meaning 3 out of 10 people will die as a part of the procedure within a year, and 85% in autologous. So it's a brutal procedure. It's a brutal procedure. So, but if you don't have too many options, so you do it. Right now, there are only few indications for autologous stem cell transplantation, and it includes severe systemic sclerosis, severe lupus, juvenile idiopathic arthritis, and juvenile scleroderma. Yes?
Do you think that the mortality rate is especially high because they wait until the person is so compromised and their life is in jeopardy before they even attempt to?
Well, there are different theories about that. So one theory is that, and it's a reality, it's not only theory, so during that period when your own immune system doesn't exist, right, so you're super prone to infections. And so that's the main cause of it's based on infections, right? So second thing is remember that you're using pretty heavy immunosuppressants and chemotherapy to wipe out all your immune cells. By itself, it can induce secondary tumors. So it's not only a selection of patients, there are quite a few other factors. My personal theory is that if you presume that most of the autoimmune diseases are driven by infection, so you don't eradicate infection by doing this particular type of protocol, and so sooner or later the disease comes back, and that's what's been shown. Again, it's a brutal procedure. It's rarely done in the States right now, and it's done for patients who basically in dire straits and who don't have too many options. So the type of therapy required careful selection of patients, consideration of various alternatives, and expertise of the transplantation team. So, and again, remember that it's a brutal procedure. So right now, if you look at patients who truly need this type of procedure, we're talking about patients with end-stage scleroderma, end-stage lupus, and that's about it. A patient with probably autoimmune pulmonary hypertension, patients who don't benefit from biologics and other things. So it's a kind of catastrophic situation. So let's talk about mesenchymal stem cells. So Dr. Friedenstein, who was my teacher, he identified mesenchymal stem cells in 1966. So he described stem cells which look like fibroblasts, which he was isolated from initially actually bladder and then bone marrow, and he called them stromal cells. And so these cells, they can give rise to various lineages, including adipocytes, chondrocytes, osteocytes, and so on and so on. So, again, if hematopoietic stem cells, they are transformed into all the blood cell types. So mesenchymal stem cells are different. So they're transformed into epithelial cells, neurons, fibroblasts, cartilage cells, fat cells, bone cells, muscle cells, and so on and so on. They are not transformed into blood cells like erythrocytes or neutrophils or leukocytes. So in bone marrow, you can find two types of cells. You can find mesenchymal stem cells and hematopoietic stem cells. They kind of do coexist nicely. So the mechanism of stem cells, mesenchymal stem cells, is completely different compared to hematopoietic stem cells. So if with hematopoietic stem cells, you're trying to basically completely renew your immune system, with mesenchymal stem cells, you're trying to change your immune system. So you're not trying to wipe it out, you're trying to kind of, reset it in a more gentle way, much more gentle way. And so we call it bystander effect. So mesenchymal stem cells, they produce various cytokines and a lot of growth factors. And these growth factors affect, for example, in the brain, they affect your neurons, they affect astrocytes, microglial cells, and so on and so on. So they are trying to normalize abnormal function. And more importantly, for those of you who went on Friday seminar, you probably remember Dr. Ross was talking about resetting Treg cells. So mesenchymal stem cells, they do activate Treg cells and they do suppress Th17 cells. So they reset the whole balance. And that's exactly how they work in autoimmune diseases. So if someone tells you that, oh, you know what, I have damaged organ and this organ will be fixed by mesenchymal stem cells, so don't try that person because it's a nonsense. So it typically doesn't happen. So there are a lot of preclinical data in animal models, and as you can see, there are quite a few various indications for mesenchymal stem cells based on clinical models, and they vary from myocardial infarction to graft rejection, stroke, some malignancies like melanoma, various kidney diseases, diabetes, autoimmune encephalitis, RA, and various things. So this is the most common type of stem cell therapy, which right now performed in California. So basically, there are two different approaches how we can get mesenchymal stem cells. So one approach is to get it from bone marrow. So bone marrow aspiration and then separation. So you can get approximately between 10 to 100,000 cells from a single bone marrow aspirate. So the second approach was a bit more brutal. It's liposuction. And so from liposuction, you can get much more cells. So what kind of problems I see with the mesenchymal stem cells? So several problems. So problem number one, that again, in our clinic, for example, we're dealing with a lot of chronic infections and infection-driven autoimmune diseases. So mesenchymal stem cells can be affected by infections. And a lot of chronic infections, they persist within mesenchymal stem cells. So what you do, you're opening a kind of jar with worms, so to say. So you're basically aspirating stem cells and putting them in circulation. So theoretically, you could spread infection. So that's number one. So number two, a single infusion of stem cells is not enough because you have to have a sustainable process. So mesenchymal stem cells, they survive after infusion for 3 or 4 days, and then they get transformed in some other cells. So the effect is very short-lasting. And it's a whole expectation that, you know, within the 3 or 4 days you're going to get better. Sometimes it happens, sometimes it's not. So I have several patients who went to Europe and get mesenchymal stem cell. So a couple of these patients, they have a history of Lyme disease, and a couple of these patients, they have poorly controlled rheumatoid arthritis, and they did benefit from those cells, but the effect was self-limited, it was short-lasting. The price was ridiculous. It's close to $35,000 per infusion. So, and so the price varies from place to place in California. There's no uniformity. So the next procedure, human embryonic stem cells, and again, they're obtained through in vitro fertilization. So you have small embryo, and then you basically start culturing embryonic stem cells from the blastocytes between day 5 and day 7. So these are the cells which can be transformed in any tissue in your body. So they're so-called pluripotent cells. And again, they can be transformed into the neuron, blood cells, liver cells, and so on and so on. So this is a specific procedure, how it's done. So you have IVF, you have embryo developed for 5-7 days, then you remove inner cell mass and you culture it, and then you keep those cells in culture. So they're stable right now, embryonic stem cells, which you can use in the clinic. So what's the difference between embryonic and adult stem cells? So embryonic stem cells are so-called pluripotent or totipotent. So adult multipotent, so they can be different only in so many cell types, not to all, so they're limited. So from the embryos, because you culture those cells, you can basically harvest any particular number of the cells without any limitations. So with mesenchymal stem cells, the number of cells isolated very, very limited. In addition, you need to keep in mind that in the United States, it is prohibited to expand and infuse back your own mesenchymal stem cells. So because FDA concerned that there's a risk of infection and reactivation of oncogenic viruses. So because of that, the number of cells which you can inject back is really, really limited. So the problem with embryonic stem cell is completely different, because you infuse foreign stem cells which can proliferate in your body, and these cells can cause tumors. So mesenchymal stem cells don't cause tumors, and again, ethically there are some issues about using embryonic stem cells for allogeneic transplantation. So this is more part of the pop culture, so about housewives of Orange County, if I'm not mistaken, or Beverly Hills, so Yolanda Foster, so she went publicly, and so she was talking publicly about using mesenchymal stem cells to treat her Lyme disease, and she was very excited because she underwent liposuction, and mesenchymal stem cells were harvested from the fat, isolated, and then infused back. So she noticed a difference. So I'm not sure for how long she'll be so happy, because typically the effect is very, very self-limited from one single infusion. But again, it's a business issue, and all around the country you can find various places which trying to convince that mesenchymal stem cells is the way to go. I did a lot of research, and I'm personally not convinced that it's any better than simple antibiotic therapy, if you know how to do it. So, but there's a big business move right now to convince patients that that's the future therapy. So this is a risk profile. So when you're using your own stem cells, the risk is kind of limited, and once you start using embryonic stem cells and artificially induced pluripotent stem cell, the risk goes up, and mainly risk for malignancies. So in the United States, embryonic stem cell therapy is, as far as I know, it's not very popular, and it's prohibited to some extent unless you're doing experiments under very strict supervision. However, there are centers all over the world offering you human embryonic stem cells as a part of therapy for various things, including multiple sclerosis and Lyme disease. And in the literature, you can find anecdotal reports. So this particular publication is talking about using embryonic stem cells in patients with MS and patients with Lyme disease. So my concern, again, that look what's going to happen 5 or 6 years down the road. Most likely these patients start having various tumors. So because this is not natural to infuse you with embryonic stem cells and just sit and wait. And actually, during one of the presentations on Friday, I don't remember who was that. I think it was one of the surgeons who was here. He described a case of a young boy who had chronic, if I'm not mistaken, it was fungal meningitis, who went abroad and got a human embryonic stem cell done, and then started developing meningiomas. So again, it's another slide showing that you can basically push embryonic stem cells in any particular direction. So I was doing a lot of research because I thought that there's a reason for stem cells to be introduced in the practice, but not the way how it is now. And so eventually I came up with the whole notion about exosomes. And so that's what we're already doing in our practice. So we're using exosomes. So what exosomes are? So these are small vesicles which are derived from mesenchymal stem cells, and they basically work as a shuttle. So they communicate between different cells, and they exchange information. So exosomes carry RNA, they carry proteins, they carry enzymes, and they're basically very efficient in terms of communications. So in 2013, 3 physicians and researchers actually got Nobel Prize for discovery of exosomes. As you can see, it's a hot topic and it's a recent topic. So exosomes are not kind of abstract things, so you can see them under electron microscopy. So you can touch them, you can harvest them, you can analyze them. So again, these are small vesicles, approximately 100 nanometers in size. So again, the beauty of exosomes is that you can produce them in unlimited numbers, and it's not so far against the FDA regulations. So FDA allows you to produce exosomes. So, and again, once exosomes are released, they can be accepted by recipient cells, and so that's how information is transferred. So again, there are a lot of publicity within the last couple of years about explosion of exosomes. And this is electron microscopy showing you how it looks like. Again, it's another slide showing exosome uptake by recipient cells. So very similar to mesenchymal stem cells, so exosomes, they have that so-called bystander effect. So what they do, they transfer nucleic acid, they transfer mainly RNA and proteins, so they can affect your immune system in a way very similar to mesenchymal stem cells, but they don't proliferate. You can harvest them and infuse them many, many times, and you can create a protocol where actually it's more feasible for your patients. So the second thing is when you infuse mesenchymal stem cells in the bloodstream, so these cells are getting differentiated in various cell types within 3 or 4 days, and they're gone. Number two, they don't penetrate through blood-brain barrier, and so that's another big problem. So exosomes actually can stay in circulation for up to 3 to 4 weeks. So they do penetrate through blood-brain barrier, so they're biologically much more efficient than mesenchymal stem cells. So again, there are a lot of data about effect of exosomes on various immune cells. So mesenchymal cell-derived exosomes, they mediate specific effects on T cells, and they induce FOXP3 positive Treg cells. They also suppress Th17. So again, that's how exosomes look in culture, and so you can wash them out from the cell surface and harvest them. And again, it's the same thing. So they transfer mRNA kind of within those small vesicles, and it's almost like exchange of genetic information between various cells. So Dr. Ross actually gave a very nice presentation on Friday, and he was talking about how exosomes work. So basically, you have unique mRNA from either placental or umbilical cord derived mesenchymal stem cells. So this packed mRNA is delivered within the cells, and cells, your own cells, start producing tons of beneficial proteins, and that production is sustainable. So you can see effective beneficial effect from exosomes for up to 8 to 12 months of a single infusion. So during that period of time, you can induce actually sustainable remission in a lot of autoimmune diseases. Again, exosomes, based on numerous studies, are much more efficient and much more safe than mesenchymal stem cells, and again, they can persist in your system for much, much longer. So exosomes also affect B cells, monocyte macrophages, and they do inhibit B cell proliferation, and they can suppress production of autoantibodies. So exosomes obviously can be internalized by macrophages, and they switch macrophages from M1 to M2 phenotype. So, and
how do you make sure that the cells that are receiving this material are getting the mRNA that's needed for these?
Well, again, we had a big meeting here on Friday, so Dr. Ross, who is kind of one of the leading researchers in the area of exosomes, he was talking about that. So his point was that he is harvesting right now mesenchymal stem cells from day 0, meaning placenta or umbilical cord. And so these are the most powerful mesenchymal stem cells because they secrete mRNA, which can tune up your immune system better than anything else. And so this, and again, he tried to do it using various mesenchymal stem cells, and he came out with the conclusion that day 0 is the best.
So the they're more highly concentrated?
Not only more concentrated, but it's, again, for example, he was talking about tumors, right? And so one of the questions was, for example, if you have a person with BRCA genes, right? So would it be possible to infuse exosomes in that person, you know, and don't have any problems? So his response was BRCA gene, for example, require p53 to reactivate the gene. And so apparently as we're getting older, the amount of mRNA for p53 declines. And so in placenta, mesenchymal stem cells carry a lot of that mRNA. So basically his point was that newborns are born healthy. And so the placenta represent kind of the ultimate health. And again, that's the choice. Yes?
So do the exosomes have their own, like, they're not turning on the intelligence of the cell to upregulate the anti-inflammatory response? They're coming in with that already?
Yes. So basically what is known right now that, like we discussed, the main product which can, for example, upregulate Treg cells, right, is the TGF-beta. And so exosomes from mesenchymal stem cells or placenta-derived mesenchymal stem cells or umbilical cord, so they're loaded with mRNA for TGF-beta. So basically you do transplantation of mRNA for TGF-beta, and so you switch your cell phenotype almost instantly.
And it's like you can take it from anyone's cord?
Well, you know, they have a very strict selection of donors. That's the key. So they select women who are absolutely healthy. They check them for various infections and other things. It's an FDA-regulated process right now.
So you have to do this indefinitely?
Not necessarily. So it's like, you know, you need to induce remission, and remission will be long-lasting. No, that's right now, basically what they're talking about, it's infusion, 3 to 6 infusions of exosomes, which can completely reset the immune system, and then effect is long-lasting, long-lasting. So again, exosomes were tried in various conditions. So, for example, right now, hot topic is asthma and also COPD. So in Europe, there's a European Commission for Exosomes, and so they actually approved the use of exosomes for 4 conditions. Number 1 is the COPD. So number 2, various autoimmune diseases. So number 3, neurodegenerative diseases such as MS, Parkinson disease, and various demyelinating conditions, and then also various muscle diseases, including coronary artery disease and cardiac myopathies. So there are articles targeting exosomes in asthma, COPD, lupus. There are articles targeting use of exosomes in MS and arthritis. And there are several clinical articles talking about exosome infusion reversing chronic renal insufficiency, exosomes reversing Parkinson's disease, exosomes reversing MS, coronary artery disease, and fatty liver infiltrates. So again, exosomes provide the same or even stronger benefits on dysregulated immune system compared to mesenchymal stem cells. They don't proliferate and are not associated with the risk of malignancies. They do penetrate via brain, via various barrier tissues, including blood-brain barrier. They cannot be used repetitively with no major problems. And the information within single exosome exceed information from mesenchymal stem cell because it's much more compact, much more concentrated. So that's presented. Questions?
Would you put that last slide, or the next to last slide back up, please?
This one?
The one before that.
This one?
Dr. Ross
He is actually a person who manufactures exosomes.
Oh, okay.
So we can ask Kate how soon the presentation will be available online. So what do you think, a couple of weeks? At least a couple of weeks. So because we're going to put it on the Lyme Tribune and on the website of our clinic, so it'll be available.
From the talk on Friday?
Yes.
Oh.
Yes.
Currently, exosomes are available to medical doctors or anyone right now?
Mainly, so FDA is highly kind of guarded all this stuff. So we're the only one in California who are doing it right now. So there are like 3 clinics in the country right now. So you have to go through a special kind of certification process and things like that.
So, Dr. Spiel that was talking the other night.
He works with Dr. Ross, actually. So he runs a clinic in New Jersey, and so that's what he's doing. But he uses it in a different way compared to how we use it. So he uses it mainly for injection. That's a different thing. So we didn't talk about that, but exosomes can be used for injections. So like joint injections, intradiscal injections, and other route of administration. And there are different type of exosomes. So the exosomes, and actually when you look at the packaging, so the exosomes, they call them ortho-exosomes. So these are exosomes which are specifically designed for musculoskeletal injections. So, and these are much more broadly available exosomes. So they're exosomes which are designed for erectile dysfunction in males. Different exosomes, completely different exosomes. They're much more broadly available. And they're exosomes, they're called immune exosomes, which specifically designed for IVs, and these are kind of real new stuff. So there are only 3 places in the States, including our clinic right now.
The ortho exosomes, there's more clinics using those?
Yes, absolutely, absolutely.
What sort of patients are you treating?
So right now, mainly Lyme patients who have various autoimmune diseases and chronic fatigue. So because in Europe, it's been described that patients with chronic fatigue respond extremely well. Again, exosomes do penetrate through blood-brain barrier, and they reset the whole gamut of neurotransmitters. So after 3 or 4 months, patients with chronic fatigue, the brain fog goes away, they start thinking much more clearly, so it's amazing.
If you had a Lyme patient that refused to do antibiotics, would you use this or would you not?
It's not a good idea. Like we discussed on Friday, I would do it in parallel. So I would do it, yeah, because otherwise it's not very intuitive. You're trying to reset your immune system, right? Because, again, patients with Lyme disease, they're dealing with infection, but they're dealing with inappropriate immune response as well. And so you're trying to reset the immune system using exosomes, but at the same time you're trying to treat them and shrink the pool of infection. And so you need to do it in parallel. And because what happens is if you just address the issue about infection, so this patient is struggling with fatigue even when the Lyme is under control. So they're still dealing with consequences of that infection.
So you're treating their co-infections simultaneously?
Whatever they have, yes, absolutely.